Thank you very much. I come from Cancer Epidemiology Unit at the University of Oxford, where the Million Women study is based. And this is a study that is quite similar in many ways to UK Biobank, although recruited in a different way. And importantly, it is linked to the same kind of data sources. So I'll be talking specifically about hospital records. I don't work primarily on cancer these days, but I do work on the Million Women study, which is why I'm based there. And focusing in particular on some examples of the work I and my colleagues have been doing. So I just wanted to start very briefly by giving a little bit more detail about what is in the hospital records and the way we conceptualise them for doing the kind of population health studies that we do. It will build, I hope, on the things that Kathy and Liam have talked about as well. I think Kathy said that the hospital data contains at its core the dates of admission and discharge, as well as coded diagnoses and procedures. And those are the piece of information that typically we're most interested in using. The actual structure of the hospital records is a little more complex than that, and they also contain a lot of information about the clinical context and the administrative context of the admission and of the consultants and the health providers involved. And I'm going to talk really only about the inpatients data, although there are outpatients and A&E data as well that are a bit more limited in detail of coverage, but also could be very useful and interesting in some studies. And I just note there are some differences between the various nations involved, but the core data is more or less the same. So most of the work that we do is in prospective studies. So that's a study, also sometimes called a cohort study. UK Biobank is a cohort, and we have a lot of information measured about participants at the beginning of the study, and then they're followed up over time. And if you like, this table shows information or a schematic of information for a number of people, and the blue bars are the periods of time in which we've observed them for some particular outcome of interest, so it might be heart attacks or something like that. And we stopped following these individuals up, and I should say we're focused on those who haven't already had the disease of interest, but we stopped following them up if they have a hospital admission of interest to us. So this first person may have had a heart attack, and therefore we stopped following them up, but we've recognised that they've had the outcome of interest. We also stop following up people when they're lost to follow-up, and death is a primary reason for this, but some people may emigrate or otherwise leave the study. And of course, eventually we reach the present and we don't know what's happened next, so we have the end of our study as well. But we use this information then to do more or less all of what I'll talk about shortly. And just to say, sort of glossed over this to this point, but hospital records are primarily administrative. So one of the primary functions of the hospital episode statistics, as they're called in England, the primary function is in resource allocation and funding of hospitals. They look at what admissions have happened or what episodes have happened to individuals in a particular hospital in order to understand what the approximate costs of treatment there, and that informs funding for subsequent years. And what that means is we have to appreciate that kind of context when we think about what hospital records mean and what can we abstract from them in terms of diseases that are being identified in the individuals in our study. And what's shown here is a validation study of some of the hospital records that we have in the Million Women study, focused on a selection of cardiovascular diseases, MI, that's heart attack, other heart disease, stroke, and VT, that's serious blood clots. And we also looked at individuals who didn't have any of these diseases. And we went to their GPs under the consent for linkage to or access to medical records and said, here is a hospital admission that we have. Can you confirm that this person had a hospital admission of this type and at that time, or might they have had it at a previous time, or in fact perhaps they didn't have it at all. And I hope it's sort of clear what this is saying, but just to break it down slightly, the dark blue parts of the bars show what proportion the GPs confirmed. They said, yes, this hospital admission occurred and the diagnosis is more or less correct. What proportion where the information in the hospital admission may reflect a sort of medical history rather than an event occurring at that time, and what proportion the GPs didn't have any information. And in the UK, that's quite important to realise that actually GPs, particularly in England perhaps, but GPs hold the most complete medical records for individuals, and so they're really the gold standard that we have for validating these things. The lesson from this is that more serious illness and acute events that would result in somebody going to hospital are picked up well in hospital admissions data, but less severe disease and some heart disease, for example, is at an early stage but might still be picked up through hospital coding. That is not quite as accurate, although it may still be very useful for some of the types of studies that I'll talk about in a moment. And we also looked at controls, and for the most part, if someone doesn't have a record, they didn't have the disease, but we have to realise that even that small proportion who do have a disease, when we multiply them up to a large study, that can be a large proportion, and Kathy talked about, and Liam actually talked about how much more information we can get from other types of medical records. So I'm just going to go through a series of examples of applications of hospital records that I or my colleagues worked on. So the first one I'd like to talk about is looking at the relationship between physical activity and fracture risk. Here, fractures are often a very serious event, particularly things like hip fracture. And if we have information on the type of physical activity, the amount or frequency of physical activity that individuals do, then we can look at how these are related. And there are hypotheses about whether physical activity can improve balance and muscle strength and things that might help prevent fractures, or whether in some cases it might provide more opportunities for someone to have a fall and therefore have a fracture. And therefore looking at these kind of questions helps to tease that out. Actually, what was found here was that for the most part, the relationships between physical activity and fracture risk were quite weak. And the exception was hip fracture, where physical activity was associated, or more physical activity was associated with lower risk. And this kind of study looking at risk factors for outcomes is a big part of what we do. I'm going to go through a sort of whirlwind tour of some of these studies, so I hope I'm not going to be sort of leaving anyone behind. But so the next one I'd like to talk about, a work of colleagues from a few years ago, and this is a different application of using hospital records, looking at one event, in this case surgery, and then in those individuals who've had that event, and also compared to those who haven't, another event, in this case a serious blood clot, so a deep vein thrombosis or a pulmonary embolism, blood clot in the lung. And what this shows is that the risk of a serious blood clot is very greatly increased in the first few months after particularly inpatient surgical admissions. It's hard to kind of put this in scale, but a relative risk gives a sort of relative measure of how much more likely it is to occur, and 100 is very, very large. To think of it another way, over those 3 months, individuals who've had an inpatient surgery have about the same risk of a serious blood clot as someone without surgery would have in 10 years. Okay, so they're very rapidly accumulating a high risk, and this can help inform understanding of the consequences of healthcare and also potentially how we deal with this clinically. Another application we heard earlier about the genetics and the new genetic data arriving in the near future is very exciting. And one of the ways we can get information about outcomes in individuals is through the hospital records, and this is part of my sort of core focus of my work, which is on aortic valve stenosis, a disease which where the aortic valve narrows and the heart has trouble pumping blood around the body. And we were looking at a particular genetic variant here, which affects levels of a cholesterol-like molecule called lipoprotein A. And comparing to the results of other studies. And the interesting thing here is that this is a relatively uncommon disease. None of these studies alone were able to show that this variant was associated at the very stringent standards of genetic studies, but together, combining this data, we see very consistent results, and UK Biobank helped contribute to that with essentially a replication in the way that we heard about earlier. And finally, another and quite different application of hospital records, thinking back to the idea that these are administrative records, actually we can use that directly, and some of the other information contained in the hospital records beyond just diagnoses and procedures and the date on which they occurred helps us to calculate, as the NHS does, costs associated with admissions. And this is work of a doctoral student of mine, Seamus Kent, looking at the relationship between obesity and costs in different healthcare contexts, and this in particular is looking at costs, again in the Million Women study, of musculoskeletal conditions. These turn out to be really important in the additional costs associated with obesity in hospital. About 40% are related to musculoskeletal conditions and knee replacements particularly. The bars here show the sort of total cost in England in age group 55 to 79 years, and the darker parts of those bars are the proportion that's attributed to overweight and obesity. And you can see most of, more than 50% at least, of knee replacements, for example, are affected by that. And so it just underscores how important the public health and other interventions related to obesity can be. So I just want to finish with just a few brief comments about summing up and also some thoughts about what we can do, the exciting things that can be done with hospital records in the future. You know, these are administrative records, as I've said. Hospital records, however, can accurately represent health outcomes, and depending on the type of study and what we're trying to do, they may be ideal or they may be less good, and we have to understand how we can make the most of them. Liam and Kathy also mentioned integrating multiple health records. I think this is an area where more can be done, particularly perhaps in UK Biobank, hospital records, primary care, etc. UK Biobank also so strong, as we're going to hear later, on imaging and other measurements, and I think these can perhaps be used to validate and enhance the outcomes that we get from hospital records and better understand what they're telling us and how we can define disease through this information. And also not just focused on individual conditions, but a bit like the health economic example that I showed you, understand the sort of spectrum of disease and healthcare use in the UK. And that's all I have to say, but just to say thank you very much, particularly to Miranda Armstrong, Jason Lacombe, Sian Sweetland, and Lucy Wright, who led the studies I talked about. And I mentioned Seamus Kent already, but I omitted him from my slide, but many others as well. Thank you.